Hi Tim, thank you again for seeing me today.
Hi Alex.
So today we're going to be discussing statins and dyslipidemia. We're going to be talking about the role of lipid modifying agents in lowering treating dyslipidemia, and we're focusing on the patients that we want to target for treatment, using absolute cardiovascular risk.
Sure.
We're also talking about the targets that we're aiming to treat to, when to add other agents, and also looking at something new in terms of assessing and managing statin-related muscle symptoms.
Great.
Yeah, giving you a bit of guidance on that.
Sounds good.
Perfect. So on our card here, we've got a little graph to start with, which basically demonstrates two things. Firstly, what we know from a huge body of evidence is that with lipid modifying agents and statins, the lower we get our LDL, which is being shown here, the more benefit we have in terms of reduction in cardiovascular events.
Right.
The other thing that this is aiming to show is that these are your high absolute cardiovascular risk patients. These are the patients that we really want to target for treatment because, as you can see, they're the ones that really we get the most bang for our buck with our statins.
Right. So these are the high ones, and they're coming down to here. Is this what you're saying?
So you can see here, say someone with a 20 to 30% absolute cardiovascular risk, we're reducing 100 cardiovascular events per 1,000.
Right. Oh, I see. Yeah, that makes sense.
Okay.
Sure.
Whereas that number's much lower with people who are at low absolute cardiovascular risk.
Gotcha.
Yeah.
Yep.
So on that, it leads us basically into our recommendation to treat lipids based on assessing absolute cardiovascular risk. This is a bit of a shift from the past where we've looked at individual risk factors, say blood pressure or lipids, and we're looking at someone's absolute cardiovascular risk when we decide to use blood pressure or lipid modifying treatment.
Yes.
How are you assessing cardiovascular risk of your patients?
Yeah, so I'm trying to do this absolute risk assessment, I guess, and so I often use the risk charts, you know, those sort of 5-year charts with
the colourful charts.
The colourful charts from that use things like the presence or absence of diabetes, cigarette smoking, age, gender, blood pressure, and lipid levels. And so try to find out whether my patients sit at a moderate or high risk on those, and then deciding whether to treat based on that. So that's my usual practice. I guess that's useful for patients who are middle-aged or older, and I think it's sort of harder when I've got young people with single risk factors, because those charts sort of give me a 5-year risk assessment. And of course, if I've got a 20-year-old with something, then their risk in 5 years might be low, but their risk by the time they're 50, I worry, is going to be high. So I sort of feel like it doesn't help me with all of my decisions, but you know, those are the sorts of things I'm thinking about when I'm seeing patients like this, I guess.
Yeah, perfect. And I guess that's what we're encouraging to use that to start treatment. And certainly for anyone low risk who might have individual risk factors who are high, reassessing them on a regular basis and focusing on lifestyle measures is our first step. Moderate risk is a little bit more complicated because we will come back to that, because they sort of fall into this grey area: do we treat, do we not? And that's based on those other factors. But high risk, definitely we want to treat everyone who has high absolute cardiovascular risk. They can be a bit tricky, I guess, particularly if they have normal lipid profiles, or they assume that they have normal levels of cholesterol, and sometimes they may not see why they need treating, and those charts that you're using can be a really nice way to demonstrate that to them. If we lower your lipids or your LDL, then we're going to see a reduction in your cardiovascular risk over 5 years. What we do see is that certainly this is data from our Medicine Insight program. Are you familiar with Medicine Insight?
Yes. Yes, I get.
So it's 600 Australian practices about, and this is looking at 53,442 patients from those Australian practices. It's just a couple. What it's done is it's looked at the people who have been prescribed statins and looked at their cardiovascular risk before starting. We can see that 49% of them were high risk, which is great. Those people should certainly be on lipid modifying agents. 16% moderate, but 35% of them were actually at low risk. And our RACGP Choosing Wisely recommendations recommend that people at low risk really shouldn't be treated rather than focusing on lifestyle modification and then reassessing their risk as their age and progresses and their things change.
I'm not surprised by those numbers. I mean, I think there is a problem of over-treating people at low risk.
Yeah.
Likewise for other cardiovascular risk factors, I think it also happens.
Yeah, definitely. So I guess it has been a bit of a shift over the last few years, focusing on those individual numbers and changing to that absolute cardiovascular risk. But it sounds like you're quite comfortable with that.
Yeah, absolutely.
Yeah,
makes
definitely.
sense.
Definitely. So once we have decided to treat with a lipid modifying agent, I think most people are pretty comfortable with statins being first line.
Absolutely.
Definitely. We're aiming to get to these targets. So LDL in primary prevention, we're looking at less than 2. In secondary prevention, it's less than 1.8. So it's a bit more aggressive in terms of treatment.
Yep.
Most of these people you're picking up with absolute cardiovascular risk, we're probably seeing the primary prevention target. Secondary prevention, because we have that slightly more aggressive treatment towards their lowering their dyslipidemia, we often see them being discharged from hospital potentially after an event, maybe on
already on the
high dose.
Yep.
Yeah,
Absolutely.
definitely. In terms of statins, what are you using? Do you have a preference?
For some reason, I often use atorvastatin as my first line statin because I think of it as a reasonably potent statin that's been around a while. And if patients aren't reaching their target on maximum doses of that, then I'll go to rosuvastatin afterwards.
Yep.
I guess that's my general way of doing things. I don't know why I chose atorvastatin, but I've always thought of that, I guess in the past, as being a pretty potent sort of statin.
Yeah.
That's why I like it, and I figure it's probably a bit cheaper than Crestor.
Cost, cost can be a part of it as well. Yeah. So definitely correct. We've sort of outlined the different potencies of the statins here, and certainly the atorvastatin and rosuvastatin, you can get up to a 55% reduction in the LDL. So looking at where your LDL is and looking at the reduction you want can be a deciding factor in which statin you choose to use.
Right.
And certainly those two are the higher potency ones, so you have more opportunity there to get that reduction. Other considerations, drug interactions. So we know that atorvastatin and simvastatin have some CYP3A4 mediated interactions. Common drugs like diltiazem or verapamil will increase their levels.
Yep.
Again, another common one is the macrolide antibiotics, things like erythromycin can interact with those two agents.
Well, yes, although I mean, in reality, how much of a problem is that if you're on a 5-day course of erythromycin?
Look, it depends on the patient and depends on the dose of statin. Often the advice might be to stop the statin in for a week if they might be primary prevention, or just for a short course. Again, higher risk if they're at a higher dose of the statin. But again, it has happened, but it's not a huge problem. Rosuvastatin and pravastatin don't also have those CYP-mediated interactions, so a good consideration with those.
Okay.
Atorvastatin and rosuvastatin can also be given at any time of day, so they can be given morning or night, so that can sometimes help with adherence, and that's because of their longer half-life.
Right. Yeah, I mean, I normally tell people to take them at night, but if they regularly forget, I just say take them when you're going to remember them.
Yeah,
so it
definitely.
seems to be better to take them than not to.
It definitely, yes. And adherence is one of those things that we do really focus on when we're looking at not getting to targets, because we do know that 67% of people after 1 year of statins aren't actually taking them. So
it seems very high.
It is very high.
67%.
It is, yeah.
Is that complete dropout from taking it, or is
Yeah.
that just not taking them all the time?
That would be, I think, just in terms of adherence, either not taking them correctly or not taking them at all.
Wow.
Yeah. So a big number there. So once we've chosen which one we want to go with, certainly looking at 4 to 8 weeks, certainly at the lipid profile and their adherence to make sure they're still taking it.
Yep.
Obviously, lifestyle factors are a big part of management in these patients, and encouraging that at every opportunity is really important. And looking for any adverse effects. When you've started someone on a lipid, on a statin, how often how soon after do you tend to reassess?
About 6 to 8 weeks, I
6 to 8
guess, to
weeks,
see
yeah.
what the lipids are like. I mean, when I start people, I say, look, there are possible side effects of these medications. Actually, in my experience, they're pretty well tolerated. Most people have heard about statins. They're so well known, and that even people who've never been on them have heard, they're going to cause problems with my muscles, or they're going to cause dementia, or they're going to cause something.
Yeah.
And so, I'll actually address those concerns up front and sort of say, in my practice, that's not a big problem, I must say. I've had a few people who get clearly myositis, with elevated CK, but that's happened only a handful of times. And so I talk about those side effects and say, of course, I don't want to give you something that's going to make you feel unwell, and we'll see how you're going.
Yeah.
But I would expect that it's probably going to be fine. And so I don't get them back in after a week of taking them to see how they're tolerating
Yeah,
them.
definitely. Yeah.
So I get them back in about 6 to 8 weeks, do their lipids again, and then are we at target and how you're going. Yeah.
Perfect, yeah. We have actually developed as well something that can help with that conversation in terms of what to expect and the benefits of statins.
Right.
This is a FAQ which will be in your prescribing software, and you can give this to patients to help a take-home message and really outlining the benefits in terms of cardiovascular risk reduction and talking about side effects, which I think are a concern, but even as a pharmacist, when I'm giving out these medications, I've changed the way I frame the conversation, focusing on benefit rather than adverse effects,
Right.
Because they are such well-tolerated drugs that are of huge benefit. So I'm not sure if that's something that could help with that conversation.
Oh, certainly.
Yeah, definitely.
Yeah. Obviously you're starting these things for life,
Yeah.
and which is, I guess, a lot of the concern that my patients have, and so the more reassurance up front is probably a good thing.
Yeah, definitely.
Particularly if there's 2/3 of people stop taking them.
Yeah.
That alarms me. I'm going to have to go back and look at my patients who are taking these
Yes,
things to see if that's true of them.
Getting them to continue to take them, and I think a lot of the time when you ask, are you still taking it, they'll say yes. So,
well, you get a sense of how often they come for repeats.
Yep. Definitely.
The thing about I give 6 months prescription, and if they're coming in 7 or 8 or 9 or 10 months later, then it's pretty clear that they're not taking them every day. I guess that's the way I would normally be alerted to the possibility that people aren't taking them regularly.
Yeah.
Sure. So.
Yeah, and definitely. And I mean the lipid profile alone, if you are checking it out regularly, will usually demonstrate
That's right.
if it's
they
not
work
working.
when you take them.
Exactly.
Yeah.
Exactly. Every 4 to 8 weeks, having a check back, looking at that lipid profile and really aiming to get to target. If they're meeting their targets, fantastic, that's great. Again, every 6 to 12 months, looking at adherence and making sure everything's on track in terms of lifestyle. Secondary prevention, we really have that more aggressive approach to management, so making sure that they're getting there to that 1.8.
Sure.
If they're not meeting their target, we want to continue to titrate the statin to the maximum tolerated dose. This is a bit of a change in thinking. I mean, often when we talk about blood pressure medications, we talk about using 2 together at moderate doses. Yep. Whereas with statins, because they are so well tolerated and we can expect an up to 55% reduction in LDL, we really want to continue to titrate them up before we consider adding another agent.
Yeah.
Do you find your patients are on board with that, or are some quite resistive?
No, pretty much. I think I explain to them, look, if you're taking a tablet, my job's to get the dose right.
Yeah.
And if we double your dose and you're suddenly getting dreadful side effects, then obviously we can reconsider.
Yeah.
But I don't expect you will, so let's have a go.
Yeah.
It's not going. I think you'll feel exactly the same, and we'll just get the numbers right.
Yeah.
I make the point that there's no prize for just taking a pill. You actually have to get your cholesterol down to the right levels for it to be worthwhile. Yeah. So I don't find that it's a huge problem. Most people are anxious about the concept of high doses of things, but I also often say to them, look, if you're having if you'd had a heart attack, they start you on a high dose, whereas I'll often start people on a low dose just to introduce the concept of something. Yeah. And then, say, look, I'm going to increase this as we go until we get it at the right level. Definitely. So if you had that conversation at the beginning, I don't have a huge problem convincing people to change their doses, I don't think.
Yeah, no, it's a really nice way to do it. But yeah, certainly we will try and get to that maximum statin dose, and then if they're not still reaching their target, then we'll look at their lipid profile and see if there's an additional agent that we can add. Again, if it's not LDL that we're focusing on and we're at that maximum tolerated statin dose, we can add ezetimibe, which adds an extra 15 to 23% in reduction in LDL. If, say, they have high triglycerides or low HDL, then fenofibrate might be the option to add there. Fish oil, I will mention. It is mentioned for triglycerides. It's something that a lot of people are taking. A lot of your patients using fish oils?
Yeah, people do take them.
Yeah, definitely.
And I'm not great at knowing about how much you're supposed to take, except that I think you're supposed to take a lot.
Yes, you're right.
And I think probably people don't take as much as they need to make it worthwhile.
Yeah, definitely. So all of our, the majority of the evidence for fish oils is with secondary prevention and triglyceride lowering, and the two things that we're looking for in that fish oil is EPA and DHA. They're the omega-3 fatty acids that have the evidence behind them. In terms of dosing, it's 2 to 4 grams of these agents. And if you consider the average fish oil on the shelf, most of those are 30% EPA DHA. So for your average product, it's usually about 10 to 12 capsules a day.
Right.
Very high doses. There are some other high dose products available, but I guess if people are going to take fish oil, ask them to talk about the EPA and DHA with their pharmacist, who are usually able to guide them in the direction of higher doses.
Do you know why they don't have bigger doses in the capsules? Is it a compounding problem or something like that?
Yeah, look, they do have some which have the bigger doses. They're more expensive, but as you can imagine, they're sort of big long-chain fatty acids, and to get enough of them into the fish oil is big capsules.
Squeezing it in.
Squeezing it, basically, to put it simply. But certainly there are some higher dose ones available now, but I think there's a lot of people out there taking fish oil might not actually get the benefits if they're looking for this.
Does fish oil have any cardiovascular endpoint data about it? Like, does it reduce mortality in people who take it? Do you know?
As far as I'm aware, the majority of the data was post myocardial infarction, looking at lowering triglycerides, which
so just looking at whether your triglycerides come down, not how many heart attacks have been prevented.
Yeah, definitely. And I mean, in terms of evidence, when we talk about all of these other things that people say this is going to help lower my lipids, there's nothing that compares to statins in terms of those cardiovascular outcomes, in terms of LDL lowering.
Yeah, I mean, I often find, sometimes I get drug reps as well who talk about how good their drug is at getting to targets, but don't talk to me at all about mortality, and I sort of think that it's a pointless conversation to be having, really.
Exactly, exactly. And we know that with things like statins, there is like huge amounts of evidence that not only do we get that effect in LDL lowering, but we are having those cardiovascular outcomes, so really enforcing that. The last little medication, not little medication, but the medication here that is listed is a PCSK9 inhibitors, and this is sort of out of interest. Have you heard of them, or have you got any patients taking Repatha?
Don't think so.
Yeah, look, they're not really used in the patients that we're talking about here. They're really a newer medication. It's a monoclonal antibody that's used in familial hypercholesteremia.
Right.
They're only TGA listed for familial hypercholesteremia and only PBS listed for homozygous familial hypercholesteremia.
Right.
Yeah, so it's a subcutaneous injection. They're very expensive. They're only ever started by specialists.
Right, so I'm not leaving it allowed to prescribe it.
Yeah, you can do follow-up, so you might see someone come from a specialist on this medication, and that's, I think, even...
then you can do the continuing authority.
Exactly, yeah. But just in case you do see them, it's a little bit of interest. They are newer drugs, and in terms, again, of cardiovascular outcomes, we haven't seen that long-term data, but we do see 57 to 61% reductions in LDL, which is, big.
So it's comparable or slightly more than a statin?
Slightly more than a statin, which we see around 21 to 55%, depending on your potency.
Do you know how often the injection is given?
Depends on which one we're doing, but usually it's fortnightly or monthly.
Right, okay. Subcutaneous, so people can do it themselves, theoretically.
Yeah,
okay.
Definitely. So the next thing we're looking at is the muscle-associated symptoms. Often this is a major concern with people who are taking statins, and we've had feedback that suggests that sometimes the reason why people stop taking statins or don't continue to take their statins, whether they have fear of this muscle-associated side effects or whether they're actually experiencing them as well. What we have seen is observationally people report these muscle-related symptoms, and we're calling it SAMs. This is a bit of an umbrella term. observationally about 29%, up to 29%, but in reality in the trial data it's more likely to be around 5%.
Right.
Vast majority of people will fall into this green area of tolerating statins, so well-tolerated drugs.
Yep. So then the studies, the 5% of people not just with CK rises, but just complaining of any muscle-related symptom.
Exactly, yeah. And those muscle-related symptoms can be with the CK elevation or,
or without.
Or without,
yeah.
definitely. What we've developed here is a bit of an assessment guide, which means you can have that conversation with the patient and saying, oh, well, look, these are more likely to be muscle symptoms related to a statin or less likely. So if you have someone coming in saying I have nocturnal cramps, it's a very different situation to saying someone who has bilateral pain in a larger muscle group that's happened between 6 to 8 weeks of starting a statin.
Absolutely.
Yeah.
Lots of people say, oh, I've got a sore shoulder, for example.
Definitely.
Because sore shoulders are common.
Exactly, yeah. And if you think about the group of patients we are treating, a lot of them are older and a lot of aches and pains have from different various reasons. So this assessment guide aims to help guide that conversation to say where it is likely to be associated or less likely to be associated. We've developed that in conjunction with a bit of a patient assessment patient handout, which again is available in your prescribing software, and a bit of an action plan which follows our management algorithm.
Right.
Yeah, so why it's important, looking at if that statin has caused the symptoms, and if you do believe it is statin related, or certainly it's very hard if that patient insists it is statin related, how do we approach that and what do we do? It follows a little process looking at the CK elevation. So if it is elevated more than 5 times the upper limit of normal, or if there's muscle weakness, we usually say stop to 6 to 8 weeks and looking at, or until the CK is within normal range. If there's no elevation, then we would, or if it's less than 5 times the upper limit of normal, then maybe stop for 2 to 4 weeks. Then we'd obviously look at the symptoms improve or if they continue. If they continue, then they're unlikely to be associated with a statin. We'd look for other reasons, but if they improve, then we'd usually re-challenge.
Sure.
Yeah. A lot of patients when re-challenged won't have those symptoms again, or if you can switch to a different statin, and a lot of the time they may not have those problems again as well.
Would you say that like a CK that's more than 5 times the upper limit of normal in a person not complaining of symptoms, should I be worried about that?
Yeah, look, that's a tricky one. There's obviously, as you know, there's a lot of reasons why that CK could be elevated. I mean, they might have gone and done a big session at the gym or something like that, and look for reasons why that might happen, obviously, with your history. In terms of if there is a very high CK elevation, person's taking statins, you might consider stopping the statin to see what happens then.
Sure.
Ideally, when we're starting as well, we're getting a bit of a baseline of where that is. So if we see it at a point where we've just elevated or started a statin, then caution would say that let's stop it and try.
But I guess what are the risks of having a high CK when you're perfectly well? I mean, is it actually a problem?
Well, yeah, and I guess looking at on the flip side of that, what are the benefits of continuing to take a statin?
Yeah.
So in most cases, particularly I guess if they were secondary prevention, we really want to maintain that statin and see the benefit in that in terms of cardiovascular risk reduction. But yeah, completely right. It depends on that patient sitting in front of you, and that's sort of where the clinical decision comes in.
Sure.
Yeah. If they're primary prevention, then again, you might stop it and see if it comes down. But again, there's no risk if there's no muscle symptoms.
Yep.
Again, if you do re-challenge and you do see symptoms again, we are talking about even looking at intermittent or twice weekly dosing. Have you got any patients doing that?
Yeah, I have. I've got a young man who's had an infarct, and so he really needs to be on a statin.
Yeah.
And so we're giving him as much as we can get away with him taking.
Yeah.
Which, it's like once a week, or so it is that process of let's just try and get something into you.
Yeah, definitely. And I guess that highlights the importance of these drugs in reducing cardiovascular risk and their role there.
Yeah.
Again, if they can't tolerate that, at that point we can look at non-statin lipid modifying agents, but obviously statins we're really highlighting as first line. Sure. Yeah. Again, as much as possible, it can be difficult, but ideally we really want to try and get to target with these patients even
Right.
looking, and
Of course.
using those other agents can have a role in this setting.
And what about that coenzyme Q10 supplement? Does that have a role in managing SAMs?
In SAMs. Look, there has been some small studies and some evidence that suggests in some cases they might reduce the side effects associated with statins.
Mm-hmm.
However, in other studies they've shown no benefit. I think the difficulty with particularly any complementary medicine in Australia is the consistency in what you're actually giving someone.
Right.
So one product is not going to be equal to another, so we can't sort of say that one is going to have that benefit.
But I guess if I've got somebody who's symptomatic who sort of says, well, what if I try some of these? I go, well, you can give it a try and see what happens.
Yeah, definitely.
But don't waste all your money on them if they're not working.
Exactly. And I think a lot of the time with the difference between what we're seeing in observational studies and also the blind studies in terms of the incidence of these symptoms, whether or not it's because we're telling people they might get symptoms and we can tell someone that they might have less symptoms, it's very unclear in terms of what we're...
Statins are they're a victim of their own success, really.
Definitely.
And I think so many people are on them that you get a groundswell of suspicion that there's got to be some conspiracy going on here or something like that.
Definitely. And I think if you ever even Google statins, I think the top 5 things are how awful they are and nothing about the great benefits that we see with them. And I think these fact sheets can really help to provide facts rather than... I
think it's a particular class of drug where I'm so conscious of that I even bring that up and sort of say, look, it's a bit like vaccination. It's one of those sorts of things which is, there's no medical doubt that these are good things, and in the right person they're amazing. And therefore you're going to encounter people who are worried about it. So I think rather than pretend that my patients aren't going to discover that or think it, I try to bring it up in the first place.
Yeah, definitely. And I think that's a lot about the conversation that we have sometimes, rather than trying to get you on board with this message. I think everyone's on board with it. It's about how we deal with those patient concerns.
Yeah, absolutely. No, that all makes perfect sense. Yeah,
lovely.
That's great.
Oh, well, thank you so much for your time. I hope that was helpful. Do you have any questions or comments?
No, I was interested to learn, because I was thinking, why would I ever prescribe any of the other statins? They aren't quite so potent. So I was particularly interested in that table that shows this little bit down here, I guess, where there are fewer problems with, say, some of these other statins.
Yeah.
Again, I guess the other thing that we haven't talked about at all is that the PBS listing for prescribing a statin thinks nothing at all about absolute risk.
Yeah, definitely.
And so that's a problem in a way, which is not something that we can solve.
Yeah, no, definitely not. But what we are looking at is there's a PBAC review of ezetimibe, and one of the recommendations of that review to the PBS was to remove that general statement about lipid-modifying drugs. So we will hope that will actually change as the PBS hopefully will shift to meet the guidelines in terms of absolute cardiovascular risk. Because yes, certainly there are a few gaps in between what the PBS recommends in terms of lipid modifying and our guidelines in terms of absolute cardiovascular risk.
Yeah.
A lot of those people will fall into that category that qualifies them. But
absolutely.
Yeah.
Particularly in secondary prevention. It's the primary prevention where there's a bigger question anyway, I think.
Yeah,
about the use of these drugs. That still is a bit of a discrepancy with what the PBS says. Yeah,
definitely. And I think hopefully in the next month or so we will see that change.
Right.
And that's when that decision in terms of the ezetimibe review, which is one of the recommendations from that, came through.
Thanks.
No problem. Thank you.
Well, no, I think that's been really helpful.
Oh, great. Thank you.
Thanks a lot, Alex.